Welcome to the deep dive. Okay, let's unpack this. When we talk about childbirth, the focus almost always ends, the moment the baby arrives.
Right, the big event.
Exactly. But what about the incredible, often overlooked journey a birthing parent's body takes after that moment? We're talking about the puerperium, or as it's increasingly being recognized, the fourth trimester.
That's the term we're hearing more and more.
Today, we're taking a deep dive into this fascinating, complex, and absolutely vital period following childbirth. Our mission? Well, it's to give you a shortcut to truly being well-informed about this critical recovery phase.
And we're drawing from detailed medical sources here.
Yes, detailed sources to unpack the anatomical, physiological, and even psychological transformations. Get ready for some surprising facts and practical insights that will definitely change how you think about postpartum recovery.
What's truly fascinating here, I think, is just how comprehensive these changes are.
Yeah.
They extend far beyond just the reproductive organs, They impact nearly every system in the body.
Really systemic, then?
Totally. If we connect this to the bigger picture, understanding the puerperium isn't just about recovering, it's about appreciating the immense adaptive capacity of the human body.
And being prepared.
And, crucially, equipping yourself with the knowledge to navigate this transformative and often challenging time. It raises an important question, really. How much do we really understand about this fourth trimester? And what are the incredible processes driving it?
That's a perfect frame for our discussion. Let's start with the absolute basics. What exactly is the puerperium?
Well, put simply, the puerperium is the period following childbirth, where the birthing parent's body, especially the pelvic organs, essentially kind of reverts back to its pre-pregnancy state.
Okay, reverting back.
Yeah, we're talking about profound retrogressive changes, the body shrinking back, so to speak. Though, of course, the mammary glands, the breasts, they actually ramp up activity for feeding.
Right, lactation starts.
Exactly. And there's a specific term you'll hear, involution, which describes this process of the genital organs returning to their non-pregnant size and function. The woman herself is sometimes called puerpera during this time.
And this isn't just a quick bounce back, is it? Takes a while.
Oh, far from it. It begins right after the placenta is expelled and typically lasts about 6 weeks.
6 weeks, okay.
By that point, the uterus has largely returned to its pre-pregnancy size. Now, for clarity, it's often broken down into sort of arbitrary divisions. The immediate period, that's the first 24 hours.
The first day?
Right. Then the early period, lasting up to 7 days, so the first week. And the remote period, which stands up to 6 weeks.
Got it.
Oh, and it's worth a quick mention that similar, though shorter, changes also occur after an abortion.
And that's why we're hearing more and more about the fourth trimester, right? It sounds like it encompasses a lot more than just, the physical side.
Absolutely. The fourth trimester is a much more comprehensive and, I think, helpful term. It recognizes the entire period from delivery until the body completes its physiological involution and the birthing parent adjusts psychologically.
So mind and body.
Exactly. It really highlights that this is a time of holistic transformation, not just physical repair.
Okay, now let's get into the body's incredible internal journey during this time, specifically the involution of the reproductive organs. Starting with the uterus. I've heard it shrinks dramatically, but can you give us a sense of just how profound that transformation is?
It's truly astonishing. Right after delivery, your uterus is still quite large and firm, roughly the size of a small watermelon, maybe, weighing around 1,000 grams.
A kilogram, wow.
Yeah, but here's the kicker. By 6 weeks, it's almost back to its non-pregnant size, weighing a mere 60 grams.
60 grams from 1,000.
Yeah.
That's incredible.
It's a 94% reduction in weight in just a month and a half. Serial MRI studies have actually tracked this dramatic decrease. Even the site where the placenta was attached contracts incredibly fast, shrinking from about 7.5 centimeters down to just 1.5 centimeters within those 6 weeks, though it stays a bit elevated.
Wow, that's just an incredible reduction in such a short time. What's actually happening at a cellular level to make that possible? It sounds like a super speed cleanup crew.
It truly is. The most significant changes happen in the body of the uterus. During pregnancy, the muscle fibers in your uterus don't just stretch. They enlarge dramatically, about 10 times longer and 5 times wider. Huge growth.
Okay.
But during the puerperium, the number of these muscle fibers doesn't decrease. Instead, the individual muscle cells themselves shrink down substantially. It's called autolysis.
So the cells get smaller, not fewer cells.
Exactly. This process is triggered by the withdrawal of pregnancy hormones like estrogen and progesterone. This hormonal shift activates specific enzymes in the uterus collagenase, proteolytic enzymes, that essentially break down the extracellular material, the protoplasm.
Where does that material go?
Your body then processes this breakdown product, and it's excreted as urea and creatinine in your urine, which is why, you might notice increased urination during this period. Even the connective tissues in the uterus undergo a similar breakdown and reorganization.
So it's like the body is efficiently dismantling what's no longer needed. What helps this process along? Are there ideal conditions?
Exactly. This efficient dismantling is favored by, well, the effectiveness of those enzymes and a state of relative oxygen deprivation, or anoxia, which is actually induced by the uterus's strong contractions and retraction after birth.
Less oxygen helps. That seems counterintuitive.
It does, but in this context, that limited oxygen environment actually helps the cleanup process. As for blood vessels, the ones that supply the placenta undergo pronounced changes. They constrict, they thicken, and they essentially close off through thrombosis. Old veins are obliterated, but new, efficient blood vessels quickly grow in their place. It's a massive vascular overhaul.
A whole new plumbing system, basically.
Pretty much. And it's crucial for the uterus to return to its normal state.
And what about the uterine lining, the endometrium, the part that sheds during a period?
Right. Well, a major part of the uterine lining, called the decidua, is actually shed along with the placenta. The superficial leftover necrotic parts become what we call lochia, the postpartum discharge.
We'll definitely talk more about lochia.
Yes. But regeneration begins remarkably quickly. It starts by day 7, growing from the uterine gland mounds and the stromal cells underneath. It's largely completed by day 10.
That fast?
Yep, except at the placental site itself. That specific area takes about 6 weeks to fully regenerate.
So if someone is trying to understand their own recovery, or a clinician is checking, how is this rapid involution of the uterus clinically assessed? Can you feel it?
You can. Clinically, we assess the rate by noting the height of the uterine fundus, that's the top of the uterus, in relation to the symphysis pubis, the joint at the front of your pelvis.
Okay.
Right after delivery, the fundus is typically about 13.5 centimeters, maybe 5.5 inches, above the symphysis pubis. It stays pretty constant for the first 24 hours.
Stays put for a day.
Then it consistently decreases by about 1.25 centimeters, or half an inch, every single day. By the end of the second week, the uterus is usually back down into the pelvis, so it's no longer easily felt externally through the abdomen.
It just disappears back into the pelvis.
Exactly. This continues until it's almost back to non-pregnant size by 6 weeks.
It's incredible how predictable that process is. But you mentioned variations earlier. What sorts of things can throw off this delicate process? Can it go wrong?
That's a great question. It can. If the involution process is adversely affected, if it slows down, we call it subinvolution.
Subinvolution, okay.
This can happen for various reasons, maybe retained fragments of the placenta or membranes, or an infection. These things can prevent the uterus from contracting and shrinking properly.
Makes sense.
On the flip side, some birthing parents who are lactating might experience what's called superinvolution, where the uterus becomes even smaller than average.
Smaller than before pregnancy.
Sometimes temporarily.
Yeah.
This is because breastfeeding releases oxytocin, and oxytocin also causes uterine contractions, which helps the shrinking process. However, if lactation stops, the uterus typically returns to its normal non-pregnant size.
So it's not just the uterus undergoing these massive changes. What about other pelvic structures that were, stretched or impacted by pregnancy and birth?
That's absolutely right. The vagina, which undergoes incredible distension during birth, takes a significant amount of time, about 6 to 10 weeks, to involute and regain some tone.
Regain tone, but does it go back completely?
It doesn't. It's important to understand that it never returns to a virginal state. The internal folds, called regae, they partially reappear by the 3rd week, but not to the same degree as before childbirth.
So some permanent changes there.
Yes. And the introitus, or vaginal opening, also remains permanently larger after a vaginal birth. The hymen, that thin membrane, also undergoes permanent changes. After childbirth, it transforms into tiny, irregular remnants, what medical professionals call carunculi myrtiformes.
Carunculi myrtiformes. Interesting term.
It essentially is a permanent physical marker that childbirth has occurred.
So, permanent physical markers. And what about the supporting structures, like the ligaments holding the uterus and the pelvic floor itself?
They take time, too. The broad and round ligaments, which provide uterine support, also take considerable time to recover from the stretching they underwent during pregnancy and labor. Similarly, the entire pelvic floor and the pelvic fascia, the connective tissue network, which bore immense pressure during pregnancy and childbirth, they also take a long time to involute, to recover from that stretching.
It really is a whole system recovery in the pelvis.
Absolutely, a comprehensive recovery period for the entire pelvic region.
We've seen the incredible internal overhaul, but some of these changes, like the vaginal discharge, are more visible and often raise questions for new parents. Here's where it gets really interesting. Let's talk about lochia. It's often one of the most talked about yet least understood aspects of postpartum recovery. What exactly is it, and what can it tell us?
Lochia is the vaginal discharge that occurs for the first fortnight, so about 2 weeks, sometimes up to 3 weeks or a little longer, during the puerperium. It originates from the healing uterine body, the cervix, and the vagina.
Okay. And what's it like? Smell? Consistency?
Well, it has a peculiar, distinct, often described as earthy or maybe fishy smell. This is normal, as long as it's not truly foul or offensive, which would suggest infection. And its reaction changes. It's initially alkaline, becoming more acidic over time as the vaginal environment normalizes.
And its color changes over time, right? I've heard about different stages. What do those colors tell us?
Exactly. There are 3 distinct phases, each telling a story about the body's healing process. First, there's lochia rubra. Rubra means red.
Rubber red. Makes sense.
This is bright red, like a heavy period, and lasts from about day 1 to day 4. It's mostly blood, along with bits of the uterine lining, fetal membranes, maybe some vernix caseosa, lanugo, remnants from the baby's time inside. Think of it as the body's first major cleanout.
Okay, the initial clearing out. Then what?
Then from days 5 to 9, you have lochia strosa. This becomes yellowish, pinkish, or maybe pale brownish. It has less red blood cells and more leukocytes, which are white blood cells, wound exudate, cervical mucus, and microorganisms. It signifies the bleeding is slowing down and healing is progressing.
Serosa, more watery, less blood.
Exactly.
Oh.
Finally, from days 10 to 15, there's lochia alba. Alba means white.
White. Got it.
This is pale white or yellowish white. At this point, it's mostly composed of decidual cells, leukocytes, mucus, cholesterol crystals, fatty epithelial cells, and microorganisms. It indicates that the healing process inside is nearing completion.
So the body is truly shedding and regenerating in a very specific, visible sequence. What about the overall amount? Is it a lot?
On average, you can expect about 250 milliliters of discharge total for the first 5 to 6 days, which can feel like a lot, requires frequent pad changes.
Okay.
While it typically lasts up to 3 weeks, sometimes the red lochia, the rubra, can persist a bit longer, especially if a birthing parent isn't moving around much, if ambulation is delayed.
So activity level matters?
It can influence it, yes. The amount can also vary. It might be lighter or scanty after premature labors, or more excessive after a twin delivery, or if there was excessive amniotic fluid, hydramnios.
So for the listener, what's the clinical importance here? What should you be watching for with lochia that might signal something isn't right?
The character of the lochial discharge is a really useful indicator of your recovery. You can learn a lot just by observing it daily when you change pads. A foul or malodorous smell is a definite red flag, often indicates an infection.
Okay, bad smell. Check it out.
Definitely. If the amount is suddenly very scanty or absent, that could signal an infection too, or something called lochiometra, where discharge is actually being retained inside the uterus.
Yeah.
That also needs attention.
So too little can be bad too.
Yes. And conversely, a sudden increase in excessive discharge could also point to an infection. In terms of color, if red lochia persists beyond the normal limit, say past day 4 or 5, it might signify that the uterus isn't shrinking effectively, that subinvolution we mentioned, or maybe that there are retained bits of placenta or membranes.
Still bleeding heavily when it should be lightening up.
Right. And finally, if lochia alba, the white discharge, persists beyond 3 weeks, it might suggest a local genital lesion like an unhealed tear or something that needs checking. So paying attention to the smell, amount, and color changes is really important for monitoring your progress.
That's super helpful. Moving beyond the pelvis now, what about the general physiological changes happening throughout the body during this incredible period? It's not just local, is it?
Not at all. Your entire system is adjusting. Let's start with vital signs, pulse and temperature. Your pulse rate might be slightly elevated for a few hours right after delivery, but it generally normalizes by the second day, though it can still jump a bit with after pains or even just excitement.
Normal fluctuations?
Pretty much. Your temperature shouldn't exceed 37.2 degrees Celsius or 99 degrees Fahrenheit within the first 24 hours. A slight reactive rise of about half a degree Fahrenheit is normal immediately after delivery, but it should normalize within 12 hours.
Okay.
You might also see a slight temperature rise around day 3, possibly due to breast engorgement when the milk comes in, but this shouldn't last more than 24 hours.
A temporary milk fever.
Kind of, yeah.
Mm.
But if your temperature goes beyond these norms or stays elevated especially, a genitourinary tract infection or other infection should definitely be ruled out by your doctor or midwife.
And your body's fluid balance and metabolism are obviously going to be impacted as well. Thirsty, trouble peeing.
Indeed. You'll likely experience increased thirst in the early puerperium. Makes sense given the fluid loss during labor, the ongoing lochia, increased urination or diuresis, and even perspiration.
Losing fluids everywhere.
Exactly. Constipation is also a frequent complaint. This can be due to a temporary slowdown in your digestive system's motility, a mild temporary ileus after delivery, and often discomfort from perineal stitches or hemorrhoids makes you hesitant to go. Some birthing parents might even experience temporary anal incontinence, which can be distressing, but usually resolves.
Okay, constipation is common. What about the urinary tract?
The bladder mucosa, the lining, can be a bit edematous and hyperemic, swollen and red, and its capacity actually increases. It's common to have overdistension without feeling the desire to pass urine, or to experience incomplete emptying, which can leave residual urine in the bladder.
So you might not feel like you need to go even when you do.
Precisely. This urinary stasis is seen in over 50% of birthing parents postpartum, making them quite susceptible to urinary tract infections, UTIs. Thankfully, any dilated ureters and renal pelvis from pregnancy usually return to normal within about 8 weeks.
And that increased urination you mentioned.
Yes, you'll also experience a pronounced diuresis, meaning significantly increased urine production, typically around days 2 and 3 of the puerperium. This is your body actively shedding the excess fluid retained during pregnancy.
Getting rid of water weight.
Essentially, yes. And because of the risk of contamination from lochia when providing urine samples during this time, it's crucial to get a clean catch sample for accurate results.
That sounds like a lot of fluid moving through the system, a real internal flush. What about overall weight loss during this time, beyond the baby and placenta?
Right. Beyond the initial 5 to 6 kilograms, that's 11 to 13 pounds, lost from expelling the baby, placenta, and amniotic fluid, you'll typically lose another 2 kilograms, or about 4.4 pounds, during the puerperium itself. This is mainly due to that increased urination, the diuresis.
Okay, another couple of kilos.
And this weight loss can actually continue for up to 6 months postpartum for many. Overall, there's a net fluid loss of at least 2 liters in the first week and an additional 1.5 liters in the next 5 weeks. The loss is even greater for those who experienced conditions like preeclampsia or eclampsia.
It's a huge systemic shift. What about blood values? Things like red cells, clotting factors.
Your blood system goes through significant changes too. There's a slight decrease in total blood volume right after delivery, but it bounces back to non-pregnant levels by the second week. Cardiac output, the amount of blood your heart pumps, actually rises significantly, maybe 80% above pre-labor values soon after delivery.
Really? It goes up after delivery?
Yes, briefly, as blood returns to the central circulation from the uterus, but it slowly normalizes within about a week. Your red blood cell volume and hematocrit values, which measure red blood cell concentration, return to normal by about 8 weeks. You'll also see leukocytosis, an increase in white blood cells, sometimes up to 25,000 per cubic millimeter. This is a normal physiological response to the stress of labor, not necessarily infection.
Good to know.
Your platelet count might dip right after placental separation, but then there's often a secondary rise between days 4 and 10, and they become more sticky or adhesive. Your fibrinogen levels, which is a key clotting factor, also remain high for up to 2 weeks postpartum.
So, more sticky platelets, high fibrinogen. Does that mean increased clotting risk?
It does. This combination creates a hypercoagulable state for about 48 hours postpartum, meaning your blood is more prone to clotting. This slightly increases the risk for thrombosis or blood clots.
Yeah.
However, your body also has a built-in protective mechanism. Fibrinolytic activity, which is the process that breaks down clots, is also enhanced in the first 4 days postpartum. So the body is carefully balancing the need to prevent hemorrhage with the risk of thrombosis.
Fascinating how the body's managing that balance. And what about hormonal shifts, especially regarding ovarian function? When do periods return? What about ovulation?
Yes, the return of your first menstrual period and ovulation after delivery is highly variable. It largely depends on whether you are breastfeeding or not.
Okay, big difference there.
Huge difference. For birthing parents who are not breastfeeding, menstruation typically returns by the 12th week in about 80% of cases. The average time is usually around 7 to 9 weeks postpartum,
So a couple of months for non-breastfeeders.
generally. Ovulation, though, can occur earlier than the first period. It might happen as early as 4 weeks postpartum in non-lactating individuals.
4 weeks, wow.
Yep. And for those who are breastfeeding, it's usually later, maybe around 10 weeks on average, but highly variable. The duration of an ovulation not ovulating is directly influenced by how frequently, intensely, and long you breastfeed. This is primarily due to elevated prolactin levels triggered by suckling.
Prolactin stops ovulation.
Elevated prolactin effectively suppresses ovulation. For those exclusively breastfeeding, meaning no other food or drink for the baby, this can provide about 98% contraceptive protection for up to 6 months postpartum. It's called the lactational amenorrhea method, or LAM.
That's a vital piece of information for new parents. So just to be crystal clear, ovulation can occur before the first menstrual period. That means you could get pregnant again even before you've had a period, right?
Precisely. That is absolutely crucial to understand. Ovulation may indeed precede the first menstrual period in about 1/3 of cases, meaning pregnancy is absolutely possible before menstruation returns.
So don't wait for a period to think about contraception.
Definitely not. This is why non-lactating birthing parents should start thinking about contraceptive measures by the 3rd postpartum week, and lactating parents by the 3rd postpartum month, though it depends heavily on their feeding patterns and whether they're using LAM effectively.
Good advice. What about other hormones like thyroid?
As for thyroid function, your thyroid gland volume typically regresses to its pre-pregnant state by 12 weeks postpartum. And thyroid function usually returns to normal levels by about 4 weeks postpartum. If you are taking thyroid medications during pregnancy, it's crucial to get your levels checked after delivery to see if your dosage needs readjustment.
Okay. Now let's transition to something many new parents are doubly focused on. The incredible milk story, lactation. This process is absolutely mind-blowing, starting right away with colostrum. Tell us about that.
Colostrum. Yes, it's that deep, yellow, thick, almost syrupy fluid secreted for the first couple of days after delivery. It's often called liquid gold, and for good reason.
Why liquid gold? What's so special about it?
Well, it's quite different from mature breast milk. It has a higher specific gravity, much higher protein content, higher vitamin A, sodium, and chloride levels. But it's lower in carbohydrates, fat, and potassium compared to later milk.
So different nutrients.
Yes, but crucially, it's absolutely packed with vital immunological components. We're talking antibodies like IgA, complements, macrophages, lymphocytes, lactoferrin, basically a concentrated dose of immune factors. Under a microscope, you'd see fat globules and these things called colostrum corpuscles, which are large white blood cells loaded with fat.
So it's not just a nutrient source, it's like a first immunization for the baby, right?
Right.
Preparing their tiny immune system.
Exactly. Its advantages are profound. It provides crucial immunological defense, acting like a protective shield for the newborn's gut and respiratory tract. And it also acts as a gentle laxative because of its unique fat composition. This helps the baby pass meconium, that first sticky dark stool.
Amazing first food. So how does the whole process of lactation work? You mentioned 4 phases.
Yes, the physiology of lactation is typically described in 4 fascinating phases.
Okay, let's unpack those 4 phases. What's phase 1?
First, we have mammogenesis. This is basically the preparation and growth of the breasts. It's the remarkable development of both the ductal system, the pipes, and the milk-producing lobulo-alveolar systems that happens throughout pregnancy. Hormones like estrogen, progesterone, and prolactin drive this.
Preparing the factory.
Exactly. What's interesting to note is that an intact nerve supply to the breast isn't actually essential for this growth phase to happen.
Okay, phase 1, preparation. Then comes the actual milk making, right? The moment your body truly starts producing milk.
Yes, that's phase 2, lactogenesis. This is the synthesis and secretion of milk within the alveolar cells of the breast. While some colostrum is present during pregnancy, the accelerated milk secretion really kicks in after delivery. True milk coming in typically starts on the 3rd or 4th postpartum day.
And that's when breasts might feel full or engorged.
Precisely. That's when breasts often become engorged, tense, tender, and noticeably warm. Now, what's truly fascinating is why this happens after birth and not during pregnancy, despite high prolactin levels then.
Yeah, why the delay?
It's because during pregnancy, high circulating levels of steroid hormones, mainly estrogen and progesterone from the placenta, actually make the breast tissues unresponsive to prolactin's milk-making signal. They block its action at the receptor level.
Ah, so the brakes are on during pregnancy.
Exactly. Once the placenta is delivered, these steroid levels plummet. The brakes come off. Prolactin can then bind to its receptors and initiate full milk secretion in your now developed mammary glands. Other hormones like insulin, growth hormone, and glucocorticoids also play supportive roles.
So the trigger is the drop in pregnancy hormones.
That's the key trigger for lactogenesis stage 2, the onset of copious milk secretion. And notably, the actual act of nursing isn't essential for this initial milk secretion to begin. Your body is primed and ready once those hormone levels shift.
So the body is primed and ready, just waiting for those hormonal signals to change. What about the actual release of milk, that letdown reflex new parents talk about, that sudden rush?
All right, that's phase 3. Galactokinesis, also known as milk ejection or the letdown reflex. Oxytocin is the major hormone driving this phase. Milk discharge doesn't just rely on the baby's suction alone. It's also about a powerful contractile mechanism that actively pushes milk from the tiny milk-producing alveoli into the larger ducts where the baby can get it.
How does that work? The reflex part.
When the baby suckles at the nipple, or even sometimes just from thinking about the baby or hearing them cry, it creates a neurohormonal reflex arc. Sensory impulses from the nipple travel up the spinal cord to the brain, specifically the hypothalamus.
Okay, brain gets the signal.
The hypothalamus signals the posterior pituitary gland to release oxytocin into your bloodstream. This oxytocin travels to the breasts and causes tiny muscle-like cells called myoepithelial cells, which surround the alveoli and ducts to contract.
Squeezing the milk out.
Exactly. This forces milk into the lactiferous ducts and sinuses just behind the nipple, making it available to the baby. This is what creates that milk ejection or milk letdown reflex. You might feel it as a tingling, fullness, or even a draft sensation in your breasts.
That's incredible, a conditioned reflex just from hearing your baby cry. Can anything inhibit this crucial reflex? Make it harder for the milk to come out?
Unfortunately, yes. Things like significant pain, maybe from sore nipples or C-section recovery, high levels of stress or anxiety, significant breast engorgement itself, and adverse psychological conditions like depression can all inhibit the release of oxytocin and therefore block the letdown reflex.
So stress is counterproductive.
Very much so. A deficient milk ejection reflex, especially in the first few days, can actually lead to significant breast engorgement because the milk is being produced, lactogenesis, but isn't being efficiently released, galactokinesis.
Okay, and the final phase. How is milk production maintained over time once it's established?
That's phase 4. Galactopoiesis. This is the ongoing maintenance of established lactation. Prolactin appears to be the single most important hormone for this maintenance phase. For continuous and effective lactation, frequent and effective removal of milk from the breast, primarily through suckling, ideally more than 8 times in 24 hours, is absolutely essential.
Use it or lose it, basically.
Pretty much. If milk is retained in the breast due to infrequent or ineffective feeding, the distension of the alveoli actually sends a feedback signal to your body to decrease milk secretion. There seems to be a local inhibitor in the milk itself. Essentially, the pressure buildup reduces the production rate. Supply equals demand.
Makes sense. How much milk does a person typically produce, and what does that require from them?
A healthy birthing parent typically produces between 500 and 800 milliliters of milk a day, sometimes more. This requires a significant energy investment, roughly an extra 700 kcal per day for their body.
Wow, 700 calories just for milk production.
Yes. This energy comes either from their diet, hence the need for increased caloric intake, or it can be mobilized from the fat stores, about 5 kilograms on average, laid down during pregnancy specifically for this purpose.
So how do we best stimulate and support this remarkable process to ensure a successful breastfeeding journey, if that's the goal?
It really starts with motivating the birthing parent about the benefits of breastfeeding, ideally starting during pregnancy. And a key point is avoiding any prelacteal feeds, giving the infant things like honey, sugar water, or formula before lactation is established, as this can interfere with the baby's natural suckling reflex and gut health.
Okay, no prelacteal feeds. What about right after birth?
After delivery, the key steps include putting the baby to the breast as soon as possible, ideally within the first hour, and then frequently, perhaps every 2 to 3 hours from day 1. Ensuring the parent drinks plenty of fluids is important, and actively managing or avoiding severe breast engorgement helps maintain supply. Encouraging early, exclusive breastfeeding in the correct position, ensuring a good latch, is also vital for establishing a robust milk supply.
What about when milk production seems inadequate, or what's sometimes called lactation failure? What causes that, and can anything be done?
True lactation failure is rare, but perceived low supply is common. Causes can include infrequent or ineffective suckling, maybe due to latch issues or tongue tie in the baby. Sometimes there's an endogenous suppression of prolactin, possibly from certain medications like ergot preparations used for bleeding, high doses of pyridoxine, vitamin B6, or diuretics. Retained placental bits can also interfere hormonally. And again, pain, anxiety, and insecurity can play a huge role in inhibiting both production and letdown.
So what helps?
Often, the most effective strategy is simply unrestricted feeding at short, frequent intervals, maybe every 2 to 3 hours, ensuring the baby is latching and transferring milk effectively. Support from a lactation consultant can be invaluable here. There are also some medications known as galactagogues, which can sometimes be prescribed to try and boost milk production.
Galactagogues, like
Drugs like metoclopramide, sulpiride, and domperidone can increase prolactin levels, which may help some individuals. Intranasal oxytocin spray can also be used sometimes to help specifically with the milk letdown reflex, not production itself. But these usually aren't the first line of treatment.
And what if a birthing parent cannot breastfeed, perhaps due to medical reasons or chooses not to? How is lactation suppressed safely?
For birthing parents who cannot or choose not to breastfeed, methods focus on reducing stimulation and managing discomfort. This includes simply stopping breastfeeding, avoiding pumping or any milk expression, wearing a firm, supportive bra, using ice packs to the breasts for engorgement relief, and taking simple over-the-counter analgesics like aspirin or ibuprofen to relieve pain.
So comfort measures mostly.
Yes, a tight impression bandage applied around the breast for 2 to 3 days can also help inhibit milk production through pressure, naturally inhibiting prolactin secretion and leading to breast involution.
What about medications to stop milk? I've heard about those.
That's a crucial point. Medical methods of lactation suppression, like using high-dose estrogen, androgens, or drugs like bromocriptine, are generally not advised anymore. This is due to the risk of potentially severe side effects. Bromocriptine, for instance, has been associated with rare but serious events like hypotension, seizures, heart attack, and even a type of stroke called puerperal stroke.
Wow, okay, so the non-drug methods are much preferred.
Definitely. The risks of the medications are generally considered to outweigh the benefits for routine lactation suppression. Your doctor will discuss the safest approach based on your individual situation.
That's a really important note for safety. And finally, just briefly, the immense benefits of breast milk for premature infants.
Oh, absolutely critical. For premature infants, breast milk offers numerous profound benefits. Psychologically, it supports bonding. Nutritionally, it's perfectly tailored and easier to digest, leading to fewer metabolic disturbances compared to formula. And immunologically, it provides essential protection against infections like necrotizing enterocolitis, which is a serious gut condition in preemies.
So it's medicine for them, really.
It really is. And there are established methods for collection, even if the baby can't feed directly yet, such as manual expression or using hospital-grade electric pumps, and protocols for safely storing and handling the expressed milk. This whole discussion really highlights how the postpartum period is far from just a passive recovery, isn't it?
Yeah.
It's an incredibly active phase of physical and physiological restructuring, a true marathon your body is running. If we connect this to the bigger picture, it underscores the critical importance of having a structured approach to recovery, going beyond just surviving the immediate birth. Which I think raises an important question for everyone listening. What tangible actions can birthing parents take to actively support this complex process? And what key things should they be looking out for as they recover?
That's a great lead-in because management and care are absolutely central to navigating the puerperium successfully and healthily. What are the core principles guiding this care? What's the main focus?
The principles are pretty clear and focused. The main goals are, first, to restore the birthing parent's overall health. Second, to prevent infection, which is a key risk during this time. Third, to promote successful breastfeeding, if that's their chosen feeding method. And fourth, very importantly, to discuss and motivate for appropriate contraception and family planning.
Okay, restore health, prevent infection, support feeding, plan for the future. What about immediately after delivery?
Immediately after delivery, close observation is essential, really a continuation of the care from the delivery room, monitoring vital signs, bleeding, uterine tone. Offering a drink or some light food, if they're hungry, is important. And perhaps most vital is providing emotional support.
Emotional support seems key.
Absolutely. While the initial feeling is often happiness and relief, new parents also need immense support. They might experience postpartum blues, significant stress or anxiety, especially if the birth was difficult, or if the newborn has issues like prematurity, illness, a congenital malformation, or, very sadly, if there's a neonatal loss. Sensitivity and support are paramount.
And rest and ambulation, getting up and moving around. How do those factor into this recovery? Is it better to rest completely or move early?
It's a balance. A good initial resting period is important, but then early ambulation, getting up and moving around, is highly beneficial.
What are the benefits of moving early?
It provides a sense of well-being, helps reduce bladder complications and constipation, facilitates uterine drainage, which helps involution, and significantly lessens the risk of serious complications like blood clots, peripheral venous thrombosis, and pulmonary embolism.
So movement helps prevent clots.
Big time. After an uncomplicated vaginal delivery, activities like carefully climbing stairs, light lifting, and resuming daily household work can usually be started gradually, as tolerated.
What about the typical hospital stay these days? It seems to be getting shorter and shorter. When is it safe to go home?
You're right, stays are shorter. Early discharge, often after just 48 hours for a spontaneous vaginal delivery, is common now in many places. This is generally considered safe, provided there's adequate supervision and support available at home, perhaps from trained health visitors, community nurses, or doulas.
But not everyone goes home that quickly.
No. Some birthing parents may need prolonged hospitalization due to medical or obstetric complications, or issues like urinary tract infections, perineal wound infections, persistent pain, or significant difficulties establishing breastfeeding. The decision is individualized.
Let's delve into those daily care routines, whether in hospital or at home. What about diet? Anything special needed?
Generally, the birthing parent can return to a normal diet of their choice. For those who are lactating, however, a diet higher in calories is needed. Remember that 700 kcal extra, along with adequate protein, healthy fats, plenty of fluids, minerals, and vitamins to support milk production. Non-lactating parents can simply return to their usual pre-pregnancy diet.
And bladder and bowel care. We touched on potential issues like retention and constipation. How is that managed?
For bladder care, the birthing parent is encouraged to try and pass urine within a few hours of delivery and regularly thereafter. If they're unable to, perhaps due to the unfamiliar position, swelling, or reflex pain from perineal injuries, which is common after difficult or forceps deliveries, we need to intervene.
Like using a catheter?
Yes. If they're unable to pass urine, or if ultrasound shows incomplete emptying with more than, say, 60 milliliters of residual urine left behind, catheterization might be necessary to drain the bladder fully and prevent complications like UTIs. Sometimes continuous drainage with an intolling catheter is needed for a day or two until bladder tone is regained. The guiding principle is always ensuring adequate bladder drainage to avoid infection and cystitis.
Okay. And bowel care, dealing with that common constipation.
Constipation is less of a problem now with early ambulation and liberalized diets, but it still happens. Usually, ensuring sufficient dietary fiber, roughage, and plenty of fluids is enough. If needed, a mild laxative like psyllium husk is upgall husk, or a stool softener can be given safely.
And sleep, which is often the holy grail for new parents, especially with newborn care demands. How crucial is it?
Sleep is absolutely essential for both physical recovery and mental well-being. The birthing parent should be protected from unnecessary worries and undue fatigue as much as possible. Providing adequate physical and emotional support, facilitating naps when the baby sleeps, is key. Any discomfort that interferes with sleep, like afterpain, painful hemorrhoids, or engorged breasts, should be actively managed with appropriate analgesics. Ibuprofen, for example, is generally considered safe for nursing parents.
Good to know safe pain relief options. What about caring for the vulva and any episiotomy or tear wounds down there?
Good hygiene is key. Shortly after delivery, the vulva and buttocks should be washed gently with soap and water, patted dry, and a sterile pad applied. Personal cleanliness of the vulval region is very important to prevent infection. If there's an episiotomy or tear with stitches, the wound might be gently cleaned or dressed with an antiseptic powder or spray after each act of urination and defecation, or at least twice a day. Caregivers should always use sterilized gloves when examining or cleaning the area.
What about pain relief for that area? Stitches can be sore.
Definitely. Cold packs or ice packs applied to the perineum intermittently can provide significant relief by reducing swelling, edema, and inflammation through vasoconstriction. Sitz baths, sitting in a shallow tub of warm or cool water, can also be very soothing. If perineal pain is persistent or severe, a vaginal and rectal examination should be done to check for any developing hematoma, a collection of blood under the skin, wound separation, gaping, or signs of infection. Again, ibuprofen is a good, safe option for pain relief.
And breast care, especially with feeding starting, what's important there?
If breastfeeding, the nipple area should be washed gently with plain, sterile water before each feeding, and then cleaned and gently patted dry afterward. A well-fitting, supportive nursing bra provides comfort and helps manage potential leakage.
What about sore nipples? That's a common worry.
Nipple soreness can often be avoided or minimized by ensuring a correct latch from the start. Frequent, shorter feedings might be better initially than prolonged ones if soreness is developing. Keeping nipples clean and dry between feeds also helps. Sometimes, though, soreness can be due to a candida yeast infection, thrush, which needs specific treatment for both parent and baby.
Okay. And you mentioned nipple confusion earlier.
Yes, that's something to be aware of. It's when an infant who has been given bottles or pacifiers early on seems to struggle with or refuse to latch onto the parent's breast. This can sometimes be prevented by helping the parent make their nipple more protractile if needed, ensuring a good latch technique, and ideally avoiding supplemental fluids via artificial nipples, especially in the early days while breastfeeding is being established.
That brings us nicely to maternal-infant bonding. It sounds like such a crucial part of this whole period, facilitated by things like rooming in.
Absolutely crucial. Maternal-infant bonding, that close connection, ideally starts in the first few moments and hours after birth. It's manifested by those instinctive behaviors: holding, kissing, cuddling, gazing at the infant. Keeping the baby in the birthing parent's room, either in their bed safely or in a cot nearby known as rooming in, is highly encouraged.
Why is rooming in so beneficial?
It helps establish that crucial parent-child relationship. It allows the parent to respond quickly to the baby's feeding cues, which helps with breastfeeding. And it helps the parent become comfortable and confident with newborn care, learning their baby's signals, practicing diaper changes, soothing techniques, all with support nearby. Baby-friendly hospital initiatives actively promote parent-infant bonding, rooming in, and breastfeeding, recognizing their profound importance for both parent and child.
And maintaining asepsis or cleanliness is obviously vital throughout this period to prevent infection.
Indeed. Meticulous asepsis must be maintained by caregivers, especially during the first week of the puerperium, which is a particularly vulnerable time for infection. This includes liberal use of local antiseptics when needed, strict aseptic measures during any perineal wound dressing changes, and ensuring clean bed linen and clothing. A clean environment and limiting unnecessary visitors can also help reduce the risk of nosocomial or hospital-acquired infections for both parent and baby.
What about immunizations during this time for the birthing parent? Are there any specific ones recommended postpartum?
Yes, several immunizations are important to consider in the postpartum period. For unimmunized Rh-negative birthing parents who have delivered an Rh-positive baby, anti-D-gamma globulin, like RhoGAM, should be administered usually within 72 hours of delivery to prevent Rh sensitization in future pregnancies.
That's the RhoGAM shot.
Right. Also, birthing parents found to be susceptible to rubella, German measles, can be safely vaccinated with the live attenuated rubella virus vaccine postpartum. This is important because rubella infection during a future pregnancy can cause serious birth defects. However, they must be advised to postpone any future pregnancy for at least 1 month, sometimes advised as 2 months, after receiving the vaccine.
So get the shot, but use contraception.
Exactly. And booster doses for tetanus toxoid, diphtheria, and pertussis, Tdap, as well as hepatitis B, should be offered at discharge if the parent wasn't up to date during pregnancy. All of these vaccines are considered safe during breastfeeding.
Okay, good to cover those bases. Beyond the general care routines, there are also some common specific challenges or discomforts during the puerperium that birthing parents might experience. Let's talk about after pain. What is that exactly?
After pain or after pains are intermittent, sometimes quite sharp spasmodic pains felt in the lower abdomen. They typically occur for the first 2 to 4 days after delivery.
What causes them?
They're caused by strong hypertonic uterine contractions, as the uterus works vigorously to clamp down, shrink, and expel any remaining blood clots or small bits of afterbirth. They tend to be more noticeable and sometimes more intense in multiparas, those who've had previous babies compared to primiparas, first-time parents.
Why more intense after the first baby?
The thinking is the uterine muscle tone is slightly less firm after previous births, so needs to contract more forcefully to achieve the same effect. The mechanism is thought to be similar to cardiac anginal pain muscle ischemia due to strong contractions temporarily reducing blood flow.
And breastfeeding can make them worse.
Yes, they are often excited or intensified during breastfeeding. This is because suckling triggers the release of oxytocin, which, as we know, causes uterine contractions. It's actually a good sign the uterus is working well, but it can be uncomfortable.
How are they treated?
Treatment usually involves gentle uterine massage by the nurse or midwife to help expel any clots contributing to the pain, followed by simple analgesics like ibuprofen. Sometimes antispasmodics might be considered if they're particularly severe, but usually analgesics are sufficient.
What if there's persistent pain specifically in the perineum, especially around an episiotomy or tear site? What should be checked?
If there's persistent or worsening perineal pain, it's crucial not just to give pain relief, but to actually examine the area carefully. The main concern is to detect a vulvovaginal hematoma, which is a collection of blood under the skin or tissues that can become quite large and painful. Early detection is key. As mentioned, hot or cold sitz baths can offer significant additional symptomatic relief for general perineal soreness.
In anemia, you mentioned iron is often given. How common is postpartum anemia?
Postpartum anemia is very common, particularly in many parts of the world, often due to pre-existing iron deficiency compounded by blood loss during delivery. Supplementary iron therapy, such as ferrous sulfate, 200 milligrams daily or an equivalent, should usually be given routinely for a minimum period of 4 to 6 weeks postpartum to help rebuild hemoglobin levels and replenish iron stores.
So keep taking iron even after leaving the hospital.
Generally, yes, for at least a month or two. If hypertension was present during pregnancy or developed postpartum, it needs careful monitoring and treatment until blood pressure returns to normal. And if proteinuria, protein in the urine, persists beyond the initial postpartum period, consultation with a physician or nephrologist is warranted.
And maintaining a chart helps track all these different aspects of recovery. What's important to record on that chart?
Absolutely. A progress chart, whether paper or electronic, is very important for clinical assessment and also helps you, the patient, understand your own recovery trajectory. Key things to track include pulse, respiration, and temperature recordings, often every 6 hours initially, then perhaps twice a day. Daily measurement of the uterine fundal height above the symphysis pubis, ideally done at a fixed time each day, always with an empty bladder, and preferably after bowel movement for consistency, is crucial for monitoring involution.
Okay, vitals, fundal height. What else?
Also, careful notes on the character of the lochia, the color, amount, and odor. Recording urination patterns, frequency, any difficulty amount if measured, and bowel movements is also important. This comprehensive charting helps monitor the birthing parent's recovery accurately and allows healthcare providers to quickly identify any deviations from the expected normal pattern. This whole journey, this puerperium, really highlights how the postpartum period is far from just a passive recovery phase, doesn't it? It's an incredibly active phase of physical and physiological restructuring, a true recalibration of the entire body system. If we connect this back to the bigger picture, it really underscores the critical importance of having a structured, supportive approach to recovery, going way beyond just surviving the immediate hours after birth, which I think raises an important question for everyone listening. What proactive actions can birthing parents take to actively support this complex process, and what should they be looking out for in the longer term, beyond those first few days or weeks?
That's a great lead-in to the next stage. Postpartum lifestyle, exercises, and those crucial follow-up checkups. Let's talk about postpartum exercise first. What are the key objectives of doing specific exercises after birth, and why are they considered so important?
The main objectives are twofold, really. First, to improve muscle tone, especially focusing on the abdominal muscles and the pelvic floor muscles. Both of these muscle groups have been significantly stretched and potentially weakened during pregnancy and labor. Second, it's about educating the parent on correct posture, how to get up from lying or sitting, how to lift the baby or other objects safely. Good posture for working positions and day-to-day activities to prevent strain.
And what are the advantages of doing these exercises? Why bother when you're already tired?
The advantages are significant and address both short-term and long-term well-being. Postpartum exercises help minimize the risk of blood clots, that puerperal venous thrombosis we talk about, by promoting circulation. They can help prevent or alleviate common issues like postpartum backache. And very importantly, strengthening the pelvic floor helps prevent long-term problems like genital prolapse, where the pelvic organs descend, and stress incontinence of urine, that leakage with coughing or sneezing.
Okay, so real benefits. What kinds of exercises are we talking about, and when can a birthing parent typically start them?
It's usually a gradual progression. Initially, often while still in the hospital or soon after getting home, a birthing parent might be taught gentle breathing exercises and simple leg movements while lying in bed, just to get things moving.
Starting slow.
Exactly. Then, gradually, they are instructed, often with guidance from a physiotherapist who specializes in postpartum recovery, on how to gently tone up the abdominal and perineal pelvic floor muscles. Correcting postural defects is also part of it. These exercises should ideally be continued regularly for at least 3 months postpartum to get the full benefit.
Can you give us some examples of specific exercises?
Sure. For the pelvic floor, the classic Kegel exercise. Consciously contract the muscles you would use to stop the flow of urine or withhold defecation. Hold for a few seconds, then fully relax. The relaxation part is just as important. Repeat this often throughout the day. You can do it anywhere.
Okay, Kegels. What about abs?
For abdominal muscles, a gentle start is to lie on your back with your knees bent and feet flat on the bed or floor. Then gently draw your belly button in towards your spine, contracting the deep abdominal muscles. Hold briefly and relax. Repeat this several times a day. More advanced exercises can be added later as strength improves.
And back muscles?
For back muscles, a simple one is to lie on your stomach with arms by your side. Then slowly lift your head and shoulders slightly off the surface, hold for a moment, and lower back down. Repeat maybe 3 to 4 times daily initially, gradually increasing repetitions as it feels comfortable.
Good starting points. When can other activities, like sexual activity, be safely resumed after childbirth?
General physical activity should typically be resumed gradually and without undue delay, guided by comfort levels. As for sexual activity, the general advice is usually to wait until after about 6 weeks postpartum. By this time, the perineum is usually comfortable, any lacerations or episiotomy wounds are well healed, and bleeding, lochia, has typically stopped. But it's very individual communication with your partner, and listening to your body is key.
6 weeks is a common guideline.
Yes. It's also worth noting, just as an aside for some individuals, that certain autoimmune disorders which might have been suppressed during pregnancy can sometimes experience a flaring response postpartum due to the rebound effect of the immune system returning to its non-pregnant state. Something to be aware of if you have an autoimmune condition.
Good point. Now, what about discharge from the hospital and those crucial follow-up checkups? What should happen before leaving?
A thorough checkup of both the birthing parent and the baby is mandatory before hospital discharge. The discharge summary or certificate should include all important information about the delivery, the postpartum course, and any specific follow-up needed.
What kind of advice is typically given at discharge?
Advice given usually covers several areas. Measures to improve general health, like continuing iron therapy if needed, reminders about doing postnatal exercises, guidance on a gradual return to day-to-day activities, crucially support and advice on breastfeeding and newborn care, and, as mentioned, the advice to generally avoid intercourse for 4 to 6 months until healing is complete.
And family planning, which we touched on earlier, that's a big part of the discharge discussion too, right?
Absolutely. Providing appropriate family planning advice and guidance is a key component of postpartum care, starting even before discharge. The best contraceptive method chosen depends heavily on whether the parent is breastfeeding, their overall health status, and their future childbearing intentions.
What are the options?
Well, natural family planning methods, like tracking cycles, can only be reliably used once menstrual cycles become regular again, which can take time, especially if breastfeeding. Remember, exclusive breastfeeding itself, LAM, provides about 98% contraceptive protection for up to 6 months under specific conditions. Barrier methods like condoms or diaphragms can be used anytime safely.
What about hormonal methods? Pills, IUDs?
Combined hormonal contraception pills, patches, rings containing both estrogen and progestin is generally suitable for non-lactating birthing parents and could usually be started 3 weeks after delivery. However, these are typically avoided in lactating parents, especially in the early months, due to concerns that the estrogen component might suppress milk production.
So what's better for breastfeeding parents?
For lactating parents, progestin-only methods are usually preferred. This includes the progestin-only pill, the mini pill, progestin injectables like DMPA, Depo-Provera, or progestin implants like levonorgestrel, Nexplanon. These generally don't interfere with milk supply.
And IUDs?
IUDs, both copper and hormonal, like Mirena, are a very effective and satisfactory method for many postpartum, regardless of breastfeeding status. They offer long-term contraception, and they can often be inserted at convenient times.
Like right after birth?
Yes. There's something called PPIUCD, post-placental IUD insertion. This can be done within 10 minutes of placental delivery, or within 48 hours postpartum, or even during a C-section. Alternatively, they can be inserted at the standard 4 to 6 week postpartum checkup. Insertion soon after birth has lower perforation rates, though potentially a slightly higher risk of expulsion, maybe around 5 to 10%, compared to later insertions.
Lots of options. And sterilization.
Yes. For those who have completed their families and desire permanent contraception, sterilization, like tubal ligation, can also be performed during the puerperium, often shortly after delivery or during a C-section.
Okay, comprehensive advice. And that all-important postnatal checkup, usually around 6 weeks, what's the main goal of that visit?
That 6-week checkup is really the key follow-up visit for routine postpartum care. While some initial guidance and checks happen at discharge, the second routine examination is typically conducted at the end of the 6-week postpartum. The aims are quite comprehensive.
What are they looking for?
To assess the parent's overall physical and emotional health, to reassess any medical disorders like diabetes, hypertension, or thyroid issues that were present or arose during pregnancy, to see if they've resolved or need ongoing management, to detect and treat any lingering gynecological conditions resulting from the birth, like infection or poor healing, to check on the baby's progress and ensure their immunization schedule is on track, and critically, to provide further tailored family planning guidance based on the parent's situation and preferences now that things have settled a bit.
What does that examination typically entail for the parent at 6 weeks?
For the birthing parent, a routine examination usually includes recording their weight, checking for pallor anemia, measuring blood pressure, assessing the tone of the abdominal muscles, and performing a breast exam, especially if they're breastfeeding. A pelvic examination is usually done at this visit to check cervical healing, uterine involution, and assess pelvic floor support. It's also an opportunity to take a cervical smear, Pap test, if one is due, or to insert an IUD if desired. Lab investigations, like checking hemoglobin again for anemia, may also be advised depending on their history.
And the baby gets checked too.
Yes, the baby is usually examined as well, often by a pediatrician or family doctor around this time, to evaluate their growth and development and to start their primary immunization series, if not already begun.
What general advice is given at the 6-week mark?
General advice typically includes resuming usual duties if feeling healthy and well recovered. Continuing postpartum exercises, especially pelvic floor exercises, often advised for at least another 4 to 6 weeks, or even longer. Catching up on any needed vaccinations like MMR or Hep B, periodically evaluating the baby's progress, and continuing exclusive breastfeeding for 6 months, if possible, with appropriate introduction of solids thereafter.
And finally, what about managing any specific ailments or issues that might still be present or arise after that initial 6-week recovery period? What are some common things?
Yes, sometimes issues linger or pop up later, for instance, irregular vaginal bleeding. It's not uncommon around 4 to 6 weeks postpartum, especially in non-lactating individuals. It might just be their first period returning. Often, reassurance is enough. However, if bleeding has been persistent since childbirth or is very heavy or irregular, it might suggest retained bits of placenta or membranes, requiring further investigation like an ultrasound and possibly a minor procedure like a D&C.
Okay. What about discharge?
Leukorrhea, which is a profuse white or yellowish vaginal discharge, can sometimes be troublesome. It might be due to overall poor health or fatigue, a specific vaginal infection like bacterial vaginosis or yeast, cervicitis, inflammation of the cervix, or ongoing subinvolution. Treatment involves improving general health and addressing any specific underlying cause found.
And the cervix itself, anything to watch for there?
Cervical ectopi, sometimes called erosion, is quite common postpartum. This is where the glandular cells from inside the cervical canal are visible on the outer surface. If it's asymptomatic, meaning not causing bleeding or discharge, ectopi found during this period should generally not be treated surgically, like with cauterization. Hormone-induced ectopi often takes longer, maybe 12 weeks or more, to regress postpartum. It should just be re-examined later, and treatment considered only if it persists and is causing bothersome symptoms.
And the dreaded backache. Lots of new parents complain about that.
Backache is very common postpartum. It's mostly due to ligamentous strain in the sacroiliac joints or lumbosacral spine, resulting from postural changes during pregnancy and the physical demands of labor and caring for a newborn. Pain, specifically over the sacrum, might point towards pelvic pathology, while pain higher up in the lumbar region is often orthopedic in nature and usually improves with targeted physiotherapy, exercises, and attention to posture.
Does a tipped uterus cause backache?
Retroversion of the uterus, where it tilts backward instead of forward, seldom causes backache on its own. However, if it's found along with persistent subinvolution and the patient is symptomatic, sometimes a healthcare provider might insert a pessary, a supportive device, into the vagina for about 2 months after manually correcting the uterine position to see if it helps.
What about prolapse or incontinence issues?
Slight degrees of uterine descent or prolapse, bulging of the bladder wall into the vagina, cystocele, stress incontinence, leaking urine with coughs, sneezes, or exertion, and a generally relaxed perineum are all relatively common findings after childbirth, especially after vaginal delivery. Many of these can be significantly improved or even cured by diligently performing effective pelvic floor exercises over several months. However, if prolapse is marked or symptoms are severe and persistent, surgical repair might eventually be needed, usually deferred until at least 3 to 6 months postpartum or after childbearing is complete.
And incontinence specifically.
For urinary and anal incontinence, the birthing parent should be carefully examined for any evidence of sphincter injury sustained during delivery. Perineal exercises are always advised as the first line of management. If symptoms persist despite conservative measures after about 6 months, referral for specialized investigations like urodynamics or endorectomanometry and potential surgical treatment may be necessary.
So, bringing this all together, what does this all mean? The puerperium isn't just a brief recovery, is it? It's really a marathon of physiological and anatomical recalibration.
Absolutely. It's largely driven by the body's own incredible self-regulating systems.
From the dramatic shrinkage of the uterus, we talked about going from the size of a watermelon down to maybe a pear in just weeks, to the intricate hormonal dance of lactation. It's clearly a period of profound transformation.
And one that arguably deserves far more attention, understanding, and comprehensive support than it often receives in our culture.
This period, often glossed over, is truly as complex and critical as pregnancy and childbirth itself. It's a testament to the birthing parent's resilience, isn't it?
It really is. But it's also a time where understanding these changes empowers them. It helps them better navigate their own recovery, advocate for their needs effectively, and make informed choices about their health and well-being.
And remember, the support and knowledge you gain during this time from healthcare providers, family, friends, resources like this can profoundly impact not just your own well-being, but also the health and development of your newborn. It really sets the foundation for a healthy family life moving forward.
Couldn't agree more.
So, as you reflect on this deep dive today, maybe consider this. How might a deeper societal understanding and acknowledgement of the puerperium, this whole fourth trimester concept, actually change the way we approach postpartum care and support for new parents? How could we transform it from being a somewhat neglected fourth trimester into a period of truly empowered recovery, adjustment, and bonding for every family?